Okay, I think we'll go ahead and get started for the evening. Welcome everyone to our first seminar of fall 2024. We're very excited to have joining us this evening Dr. Rebecca McOnie. We have 4 seminars set up for the fall, one each month. We look forward to you all joining us for each of those. This evening, Dr. McOnie will be presenting on minimally invasive surgery in the abdomen. What can we do? Dr. McOnie did her veterinary training at the Western College of Veterinary Medicine in Saskatoon, followed by an internship at Arizona Equine, and then moved to Central New York and joined the team at Cornell, where she completed her large animal surgery residency. Since completing that and achieving board certification, she's been working here at Cornell as a clinical instructor and also completing a minimally invasive surgery fellowship, which is very cool, and not many people do that. So we're very honored to have Dr. McOnie tonight. She's also, in very good news, staying at Cornell as a faculty member. She'll be starting as an assistant professor in large animal surgery in November. So we're thrilled to have her. As a reminder, please use the Q&A for questions. We may answer some of your questions directly. We'll also save some to the end and ask Dr. McOnie to weigh in on them. And feel free to, raise your hand if you have any concerns or anything like that. But we'll go ahead and turn it over to Dr. McOnie.
Wonderful. Thank you so much for the introduction, Dr. Nickelbein. I'm very happy to be with you this evening and excited that so many of you would join us. So I have taken an interest in minimally invasive surgery within the bigger picture of large animal surgery, which comprises mostly equine surgery and then a little bit of farm animal surgery. But what we'll be focusing on today is obviously equine surgery and minimally invasive surgery, specifically in the horse abdomen. And see if I can advance for you. So as far as minimally invasive surgery goes, which is abbreviated as MIS, kind of throughout this presentation, or you might hear that elsewhere, you might have a variety of questions. First of all, what is it? What does this even mean? How do we go about doing it? How do we perform minimally invasive surgery? What are the advantages? Why should we bother or really care about minimally invasive surgery? Who are the candidates? So which horses might we potentially operate for these minimally invasive surgeries? And then, of course, what can't you accomplish with minimally invasive surgery that you might accomplish otherwise in general with surgery? So what are the limitations insofar as applying minimally invasive surgery? So you may have heard of minimally invasive surgery in the context of human procedures and the terminology of keyhole surgery. So MIS involves making numerous small incisions, so multiple small incisions, and then inserting a telescope that has a camera attached to it as the primary way of viewing within, in this context, it's the abdomen. So when we do this type of keyhole surgery within the abdomen, we call it laparoscopy. So laparoscopy is minimal invasive surgery or keyhole surgery within the abdomen. We use the scope, the long telescope, to be able to see, and then we use long shafted instruments to be able to manipulate tissues within the abdomen, to be able to clear our field of view, to be able to suture or stop bleeding, remove masses, that type of thing. And you might think of the abdomen as being just kind of squished full of different organs. So the way that we are able to essentially create space and separate the intestine from other folds of intestine, or the liver, for instance, is to insufflate, so add carbon dioxide, CO2, into the abdomen. And when we do that, it essentially allows those intestinal segments, the organs, to kind of fall away from each other. And that creates some space for us to be able to move the scope throughout the abdomen, and then also move instruments and manipulate the tissues. So creating the space within the abdomen using the carbon dioxide is really what allows us to move around safely within the abdomen. So this same sort of keyhole surgery, if it were performed inside a joint, would be considered arthroscopy, which is potentially something you've heard of. Same idea, it's a similar minimally invasive surgery where you're using a longer scope. So it's longer when we have to go into the abdomen than into a joint, but a scope attached to a camera that gives you visualization of a space. And in the joint, we use fluid to be able to expand and create space so that we can look at cartilage. And within the abdomen, we use carbon dioxide to create that space so that we can have a good look around and manipulate the tissues. So keyhole surgery, it comes in many different forms, minimally invasive surgery in many different forms. It could be laparoscopy, for instance, which is within the abdomen, and that's what we're going to focus on today. And it could be, for instance, arthroscopy, where it's within the joint. And you might have heard about minimally invasive surgery, or particularly laparoscopy, in the context of humans again. And in people, one of the major advantages to avoiding larger incisions and making small incisions is that you limit scarring. And that's a pretty big deal for people. In horses, it's less of a big deal, but it is one of the advantages of minimally invasive surgery. However, the other major goals and two big advantages of minimally invasive surgery in horses are limiting tissue trauma and pain. So we're making smaller incisions, ultimately decrease the amount of dissection and surgical extension that we have. And the other big deal is that usually we get these animals back to work faster than they would be if we were having to make a big incision. So these are some pretty big goals with MIS that can really essentially promote this type of surgery and promote your horse's athleticism ultimately down the road as well. So breaking down these advantages and the disadvantages a little bit more, because there are pros and cons with pretty well everything that we end up doing. So again, with laparoscopy, we're big picture, we're really trying to minimize pain, trying to minimize the extent of trauma, and we're trying to get these horses back to work in a very timely manner. And most of the time, that's quite successful with this type of procedure. Some of the other advantages, which we as surgeons really, really appreciate, are that we get a beautiful view within the abdomen. So using a long telescope allows us to get into some locations within the very large horse abdomen that we otherwise wouldn't necessarily, we might be able to feel if we made a large incision, but we wouldn't necessarily get to see easily. So the scope and laparoscopy can often allow us a view and access to certain parts of the abdomen that we wouldn't necessarily be able to operate or easily get to with an open incision. So that's just going back to our terminology. So when we think about minimally invasive surgery or laparoscopy and that keyhole surgery, that's multiple small incisions. And the corollary, or kind of the opposite of that as far as the extent of surgery that we do, would be what we consider open surgery. So that would be our more traditional approach, where we're making a larger incision, we're being able to easily potentially put our hand into the abdomen, manipulate tissues mostly with our hands rather than with our scope or with the long-handled instruments. So one of the other advantages to laparoscopy is that in many cases, depending on the reason for it, we can do it standing. And when it's performed standing, it's with sedation and local anesthetic, so just local numbing, but the horse does not have to be induced under anesthesia and laid down on their back, which is a much more intensive process. It can be done safely, but is a much more intensive process, especially for big horses. and disadvantages of laparoscopy. So depending on the scenario, sometimes the cost of laparoscopy could be greater than doing open surgery. And the other concern that we often have is, although we can create some space in the abdomen by adding carbon dioxide and having the intestines fall away from other segments, we also need to fast the horse. We need to decrease the amount of fill that the horse has in their colon and their small intestine so that it's not taking up all the space within the abdomen. Because if the horse has a gut full of feed and manure, then it's very hard for us to be able to see everything we need to and to essentially move around the abdomen. So we do usually have to fast horses for a little bit longer before laparoscopy than we would for some of the open surgeries that we do. Some will consider the really extensive and specialized equipment a disadvantage to laparoscopy, but we are very lucky at this institution at Cornell. We have really a world-class setup, particularly in our equine hospital, for laparoscopy equipment, as far as the scopes, the 4K HD sort of cameras attached to those scopes, and the really extensive equipment. So we're very lucky on that front and really happy to be able to offer that to you. Kind of in the same vein as far as the training goes, we're at an institution where we've really tried to advance in our own training. There are numerous surgeons who are adept at laparoscopy and are very excited to move forward with laparoscopic surgery to be able to help your animal. Another potential disadvantage would be what we call the conversion to open surgery. So that would be, okay, we're hoping to do this surgery laparoscopically, but for some reason that fails. Maybe the horse really will not tolerate standing for the procedure, and now we have to do it under anesthesia, and that would be a conversion to open. So I think some people might see that as a disadvantage. Ultimately, we have the advantage of being able to start and consider laparoscopy. It's not always appropriate, but should certainly be a consideration as far as options for your horse, depending on the problem. So you might be wondering a little bit more at this point, how does laparoscopy actually happen? So like I've alluded to, it can be done both standing or under general anesthesia. So on the left here, you see a picture with a horse standing in stocks. The horse's flank has been clipped, prepped up, and the horse is draped. We have a team standing around the horse using long-handled instruments, including the scope, to be able to evaluate the abdomen. And then on the right-hand side, we have a couple of pictures of a horse that has been anesthetized. So this horse is placed on its back. You're seeing the legs sticking up at the four corners there. And we've been able to, just like in people, we put the scope into the port right at the belly button or at the umbilicus. So that allows us to be able to get into the abdomen with the scope and then make several other portals for our instruments. So on the left, this is a picture of Dr. Campoy just providing local anesthetic before surgery. Local anesthetic is really important when we're doing these standing procedures. The horse is sedated, but their flank also needs to be numbed in order to make it comfortable or tolerable for us to go ahead with surgery. So we go ahead, sedate them. Our anesthesia team looks after the local anesthetic. They're draped, like I mentioned, and then oftentimes when they're standing, it gets a little bit precarious at times, but have a lot of instruments kind of balanced on top of the horse at times. And you can see in this picture on the right, we have the insufflation tubing. That's the tubing that will allow us to put gas into the abdomen and create that working space. So a little bit more detail on the instruments that we use. The major components of instrumentation are the scope. So the telescope, and you can see that, hopefully you can see my cursor here, but the telescope right here, and it comes in different lengths. So We have several different scopes, several different lengths rather, that are used depending on the position of the horse, if they're laying down, standing, depending on what we're trying to look at in the abdomen. That's attached to a camera, and then it gets hooked up to a monitor as well so that we can see the beautiful image. So the telescope and the instruments all run through these little cannulas. So these are little tunnels essentially that sit within the body wall. And so they sit through the abdominal wall and allow us to insert and remove the scope and the instruments very easily without causing a bunch of disruption or pain to the muscle in the body wall. The other cables here, this is the insufflation tubing, and then we also have a light source. So if we didn't have the light source hooked up within the abdomen, it would be very dark. We really wouldn't be able to see anything, but the light source allows us to be able to evaluate what's going on in the abdomen. All right, so you can see on the left here, we have the surgeon inserting the telescope into the abdomen, and we're starting to get that first view within the abdomen on this side, which is of the spleen right in this area. And now on the right, an assistant is holding on to the scope. And you can tell, again, it's quite long handles. There's a fair amount of ability to manipulate it, move it out of the abdomen, further in. And then the surgeon is inserting an additional cannula to start putting the instruments into the abdomen. And the instruments will, again, allow us to manipulate well, truly, we have a real multitude of instruments. So most of the primary instruments that we use are forceps to allow us to move or manipulate different tissues. But there are plenty of others, including things like scissors, little dissectors. Sometimes if we're removing tissue, we have to trap it in a bag, and then we use the bag to get the tissue out of the abdomen. Sometimes we need to do suction within the abdomen. Excuse me. And then there are a few other devices as well, like these ones that help us with preventing bleeding. So they help us essentially create clotting and then allow us to cut tissue without excessive bleeding. So these are very helpful instead of having to add in a whole bunch of sutures, which within the abdomen like this, trying to put sutures to stop bleeding is a very challenging technique. So these instruments make our surgeries a lot more efficient. And then there are other instruments like staplers that we can use. Again, in some cases, that's to remove tissue or to stop bleeding. Tacking instruments, for example, if we're trying to close off an area using mesh, sometimes we need to use a stapler or a tacking instrument. So a few pictures here to show you these different instruments. So in this case, that's one of the instruments that helps to prevent bleeding as we're cutting tissue. And that's one that we rely on pretty heavily. It's a very handy instrument to use. And again, you can see, especially when there are three things, so 2 instruments and then a scope, you really need a surgeon and an assistant to be able to get these procedures done. And then over here, we have a forceps that's inside the abdomen. And in this case, we're trying to remove a testicle from the abdomen. So we're having to use a dilator to make the body wall a little bit bigger. And over here, this is the handle of a bag. So it's a catch bag to be able to remove some tissue from the inside of the abdomen. So you can tell that these are all like slightly different in length. That can be one of the limitations if our instruments are too short for the size of the horse. But we're pretty lucky in that we have a very good variety of instrumentation available to us and can usually make something work to get the procedure done. All right, so that's kind of the overview of how we get laparoscopy done, logistically, and the basics there. So you might now be curious, what do we actually see when we go into the abdomen with the scope? You had that bit of a sneak preview of the spleen. And so now I'll show you a few of the other organs that we can see. So at this point, you can imagine that you're standing on the left side of the horse, just like, let's say, just like these surgeons right here. So you're standing at the left flank and you've just put the scope in. And now the scope is pointing forward towards the horse's nose. Way up here at the front, that's stomach. And then we have spleen sitting right back here. The kidney would be right behind this ligament. And this is a little bit of small intestine that's draped over the spleen. And you can appreciate in this image that, again, we have space in the abdomen. And that's because we've allowed air into the abdomen. We've put CO2 in there additionally to be able to create that, that space to move around. All right, and now you're standing still on the left side, you're pointing the scope backwards, and you can still see this kind of blue seal fin sort of organ back here, which is the back part of the spleen. And we have some small intestine still draped back here. And this is small colon. So the different parts of the horse's intestine generally have different characteristics that help us identify those parts. We can't always be very specific. I can't tell you precisely, is this the very end or the very beginning of the small colon? But I can tell you just by looking at it, this big band and the sort of folds that it has, that would be small colon. We also see this sort of fatty presence that's in the mesentery, in the sheet that suspends the intestine. All right, so now if you are standing on the other side of the horse, you're standing at the horse's right flank, and you have put the scope in and you're looking forward again. The horse's nose is up this direction. It's a totally different view from this side. So this is what we're seeing right here. This is duodenum hanging down right here. And the duodenum is the very first part of the small intestine that comes off the stomach, starts off the small intestine. It hangs right over the horse's cecum, which you can only see a small part of the cecum right here. The cecum is a big kind of fermenting vat in the horse's GI tract, but we have the duodenum, the little bit of small intestine here, and it sits right over the cecum. And this other kind of darker red structure that you're seeing, it has different lobes like this, and that's liver. That's right there. So we see the liver primarily on the right side of the horse's body. The other interesting thing that we can see if we sneak up forward with the scope on the horse's right side is the epiploic foramen. So you might have heard of the epiploic foramen from the standpoint of colic in horses. Sometimes horses can get their small intestine, it's usually the small intestine, stuck into the epiploic foramen. So this is the visual of the epiploic foramen. It is truly a hole. It's a little bit of a trap within the horse's abdomen that most of the time is not a problem. But for certain horses, it can be problematic, and their small intestine gets sucked up into the epiploic foramen, and that can cause some signs of colic for them. All right, so that was the view when we were standing on the right side and we were looking forward. Now, if we're standing, if we're standing on the right side and looking across the horse's abdomen, again, it's a completely different view. So you can tell that there's tons to look at here. And one of the major reasons, again, that we can see all of this is the space, because this horse has been fasted and because this horse is standing. So if this horse were on its back under anesthesia instead of standing, we wouldn't be able to see this same view at all. Again, it would be entirely different. So on the right side here, looking across the abdomen, we're seeing the end of the small intestine, which is the ileum right here. And the ileum, that end of the small intestine, runs right into the cecum, into that fermenting vat. All right, so I have a video here for you. So you're back. This video is taken with the scope into the left side of the abdomen, looking towards the horse's tail. So what you're seeing back here is bladder, bladder sitting right here. This is the abdomen, like the abdominal muscles right here. We have some small colon, and then this is uterus that's kind of snaking right here. So I'll press play and you can try to follow these organs. So again, bladder back here, uterus, and now we have a view of the ovary that's hanging. Now the scope is coming forward towards the horse's nose. The kidney would be hiding behind that curtain. And you should recognize this guy now, that's the spleen. And now this turns into a video of a surgery that I'll give you a little bit more information on soon. But I think it's a nice video in that you can start to see that one of the techniques that we can use with laparoscopy is to introduce suture, and we are able to suture within the abdomen. This is a very challenging technique, but it certainly can be done, and it's something that we do on a, let's say, semi-routine basis. All right, so another little video for you here to show you the manipulation of the intestine. So this is a little video showing how we can move along small intestine. Let's skip forward for you. So in this case, the surgeons are using large forceps to be able to move right along the small intestine. And this technique allows us to have pretty good view of the small intestine. You can tell this is a little bit tricky. The small intestine is very long in a horse and tends to like to roll up on itself a little bit. So as they go, the surgeon's having to untwist, they adjust the view with the scope a little bit, but overall getting a pretty good picture of what the small intestine looks like. And the small intestine can be a culprit in some horses that have chronic signs of colic. So this technique can be a real advantage for investigating the small intestine. All right. Okay. So at this point, we've talked about, in general, how we do laparoscopy. We've shown you a little bit of what we actually see when we put the scope inside the abdomen. That really depends on whether or not the horse is standing or under anesthesia, and from which side we're putting the scope into the abdomen. So at this point, I'll go over some of the reasons that we actually do laparoscopy and talk about which animals might actually be candidates or potentially need surgery like this. So these are really the most common reasons that we would do laparoscopy at this hospital. It probably varies a little bit hospital to hospital, but overall, these are, I would estimate, probably the most common reasons at a lot of hospitals that laparoscopy is performed for horses. So in particular, we perform laparoscopy to take out testicles. So horses that have retained testicles that are called cryptorchids, and we can remove testicles in order to completely castrate them. We can also remove ovaries. And usually the reason for removing ovaries is because occasionally horses will develop tumors of the ovary, and often the type of tumor that they develop increases their testosterone, and really increased testosterone makes a mare act like a stallion, which generally isn't very desirable. So two of the very common reasons for us to do laparoscopy are essentially associated with reproduction and the reproductive tract. And then other reasons are related to colic. So exploring the horse's abdomen, so taking a look at the small intestine, at the colon, to the best of our ability. If the horse is chronically colicking, it's not these cases where the horse is acutely, very severely painful, rolling on the ground. Those generally aren't the cases that we would evaluate with scope. But horses that are persistently a little bit off can often benefit from our evaluation by laparoscopy. The other reason to scope these horses for recurrent colic is to try to prevent colic in the future. So horses that get epiploic foramen entrapments, when their small intestine goes into that hole that I showed you, or if they get nephrosplenic space entrapments, we can essentially close off those areas where the intestine would get trapped and prevent that type of colic from happening again for this horse. So we'll go into a little bit more detail about the nephrosplenic space. That might be familiar to some of you, but we'll revisit that as well. So some other broad reasons for doing laparoscopy: we can repair hernias, we can remove bladder stones like this one that's shown here. We can repair uterine or rectal tears, usually the very bad uterine or rectal tears. And then we can evaluate and remove scar tissue in some cases. We can manipulate the uterine position, and we can at times flush an infected abdomen. So all of these procedures are kind of with caveats in that doing it laparoscopically can work very well in some scenarios and wouldn't be appropriate in others. So on the right side here, this is just a picture of a fair amount of scar tissue that has formed around the inside of the horse's inguinal canal. So this is a horse that had a castration site infection, and the infection has ascended or come up into the abdomen along the spermatic cord. This is all infected tissue, but in order to get that out, the scar tissue around here needs to be detached first. All right, so now we'll look into kind of each of these reasons for laparoscopy. So first of all, like I mentioned to you, ovary removal. This would be a relatively common reason for us to do a standing laparoscopy. And tumor removal would be, again, one of the more common reasons for us to be removing an ovary. Occasionally, horses will get pyometra, which is an infection that's present within the uterus. And if that horse doesn't need to be bred down the road, or it's very, very difficult to clear out that pyometra, that uterine infection, then we can remove the ovaries for that horse, and that would generally help to clear the infection for the horse. The other reason that we might remove ovaries is for behavioral modification. And this is a little bit more controversial and really depends a lot on the type of behavior that the horse is exhibiting, their response to some other medications, their behavior during heat cycles, for instance, and oftentimes it's a fairly last resort opportunity to try to correct bad behavior in a horse or really difficult behavior that's impeding training. So most of the time in these scenarios, we're really trying to rule out any other potential cause of difficult or challenging behavior before we take out ovaries. And hormonal testing can be helpful, particularly in detecting tumors like the one that's pictured here. All right, and then cryptorchidectomies. So this is removal of a retained testicle. And generally, we're doing laparoscopy for removing testicles that are in the abdomen. The retained testicles can be either in the abdomen or in the inguinal canal, so between the abdomen and the scrotum. But laparoscopy is most helpful when the testicle is still in the abdomen. And you can see on the right here, this is a picture of the testicle dangling within the abdomen, close to the inguinal ring right here. We have a really nice view of that when the horse is in a standing position. On the far left here, this testicle is before we created very much space within this horse's abdomen, but this horse is under anesthesia and laying on its back. So the testicle looks a little bit more concealed, and we have a little bit less room to work in this case. So oftentimes in the case of cryptorchid horses, their general behavior, their persistent stallion-like behavior, can give them away. So sometimes you might have a horse that you think has been gelded, but they continue to act like a stallion. And hormone testing can help you to evaluate whether or not they do actually still have a testicle present, maybe a testicle that is hiding in the abdomen. Alternatively, some of these horses, you know from a very young age that one testicle hasn't dropped, and this is a procedure that can be scheduled when you're ready to have the horse castrated. All right, so nephrosplenic space ablation. Now we're going from these reproductive surgeries towards the colic type procedures. And this is a preventative surgery for a specific type of colic. And the specific type of colic is a nephrosplenic space entrapment. So all that means is that the intestine is getting trapped in this space that is between the kidney and the spleen. So in this diagram on the left here, you can see that the spleen, it kind of hangs off this curtain just beside the kidney. And this diagram shows a horse's intestine that is entrapped. So this horse would be colicking. Its colon is sitting up in this nephrosplenic space. So in order to avoid having this intestine become trapped in this trough that is present between the spleen right here and the curtain hanging down from the kidney, we can suture this area closed. So instead of being a big V, we kind of make it into a little bit of a roll top so that if the intestine comes up the side of the body wall, it will just essentially roll off and it doesn't get totally hooked into that V that is present. So on the right side, this is an image that you've seen before when you look into the horse's abdomen from the left side. And this is intestine, so small intestine that is sitting in that trough, just like that is pictured here on the left. So that intestine is sitting down in the trough between the spleen, right here and between this curtain that is hanging down from the kidney. So the ablation of that space, again, is performed by suturing this V trough closed. And we, again, use cannulas with our long-handled instruments. We use suture and needle drivers to be able to move the suture through the tissue. And ultimately, once this area is closed off, once we suture the spleen over to this ligament right here, to this curtain, it will heal and it creates this roll top sort of surface. So if there's any intestine that comes up here on top of the spleen, it will generally fall back down. It won't have a spot to get trapped up here. A few other pictures to help you visualize this. So this is that V trough where we can have intestine that gets trapped right there. And now in this case, we're in the process of starting to suture that closed to start creating that little roll top right here. So suturing that curtain to the top of the spleen to just close off or ablate that space. So that's one of the procedures that we can do to prevent that type of colic from recurring. In some cases, if horses have this type of colic, so a nephrosplenic space entrapment, their gut is stuck up here, sometimes they don't get better with only medical type treatment, so only with fluids or Banamine, that type of thing. And in those cases, we can often do surgery on them and we will find something similar to this, where their intestine is sitting in that area. Sorry for the flipping of slides. So their intestine is sitting in this area and we can use an instrument to push the intestine out and then we go ahead and close them. So we can both fix the horse with the surgery and then we also prevent that type of colic from occurring again. To be clear, this doesn't prevent all types of colic, but it does prevent that specific type of colic from recurring. All right. So one of the other potential causes of colic for stallions in particular is a scrotal or an inguinal hernia. So if you look at this diagram on the right, the top right here, you'll see the small intestine has descended through the inguinal canal, just like the testicle has, into the scrotum. And now all of that intestine is sitting down in the scrotum. And this is not where it should be. This is a pretty tight canal. It's squeezing the intestine and it's changing the blood flow to the intestine. So this becomes quite painful for the horse. So once that intestine has been moved out of the inguinal canal, then we usually want to close up this ring because we don't want the horse to have this repeat. We don't want the intestine to sneak down the inguinal canal again. And there are a few different ways we can do that. So this picture on the left shows this canal, which is really just a slit in the muscle. It's not a gaping hole, it's just a slit in the muscle. And it shows on the left here, this image shows that we've been able to suture that ring closed. And this is appropriate usually in foals or in ponies, maybe small horses, depending on how small they are. The suture can usually hold that area closed. In mature, larger stallions, sometimes we need mesh to be able to close off that site. And it's applied in a little bit of a sort of envelope fashion here. It kind of folds over the spermatic cord that in this stallion's case is going down into the inguinal canal, and it prevents other tissue apart from the spermatic cord from going down into the scrotum. So we have different options for fixing this particular type of hernia. All right, and then going back to more chronic colic. So the horses that we want to potentially explore with laparoscopy are usually those that have had chronic signs. Again, these aren't the ones that are down thrashing, that are really bloated and distended. These are horses that have been intermittently colicking for longer periods of time. Sometimes they have weight loss, maybe they have diarrhea, maybe we're concerned that they have cancer, for instance. And ultimately, we end up fasting these horses, again, to empty out the bowel, to decrease the amount of fill in the intestine, so that when we go in with the scope, we have a pretty good view of as much as we can possibly see of the intestine. And the goal in a lot of these cases, apart from to see, is there an obvious mass? Is there an obvious misplacement of some portion of the intestine? Is often to biopsy the intestine, especially if we do find something that's abnormal, for instance, a mass. This image on the left shows that at times we go from having just the cannulas present to potentially extending the incision. So this is conversion to open, or to what we might call hand assisted. So it's kind of an in-between, I would say. We're not making a huge incision, but we are making a bigger incision than we would often use for laparoscopy. So this can allow us a more thorough evaluation of certain portions of the intestine if we really feel that that's necessary. Might allow us to bring the intestine outside if we think that that's the best way to get the appropriate biopsy as well. All right, this is an example of the uteropexy, which I alluded to the fact that we can potentially manipulate uterine position. So if you see on the left here, the uterus is coming from the pelvis and it's really tilted downwards. And in some horses, this can contribute to chronic infection in the uterus and sometimes infertility as well. So in consultation with a thyrogenologist, so one of the reproductive experts, depending on the horse's progress with other treatments, it might be appropriate to try to change the position of the uterus. So instead of hanging down like this, bringing the uterus up to a more level position, allowing infected material to be essentially excreted or removed from the uterus more easily and potentially clean up or clear out infection from the uterus. And then tear repair. So these are the opportunity for repairing tears is really only in cases of quite severe uterus or rectal tearing. So this is an image of a rectal tear on the left here, and then a uterine tear on the right. So if it's full thickness, if the tear goes all the way through the uterus or all the way through the rectum, we can use laparoscopy to help identify the location of the tear. We can essentially guide the repair, which we might not be able to do otherwise. It might be more of a blind technique. And it also helps us to look around, because if the uterus is breached or if the rectum is breached, there will most likely be contamination, so dirty material within the abdomen, and we want to be able to identify that and remove it to give the horse the best chance of surviving and moving on with their life. All right, and I alluded to this a little bit, removing scar tissue already. So you saw this picture on the left where there's some scar tissue present around the inguinal canal right here. This is a big infected castration site that has come up towards the abdomen. And this is an image essentially demonstrating the use of one of those instruments that helps us to cut tissue and avoid bleeding. So this type of instrument is very helpful for dealing with the scar tissue. We can get rid of this, cut it very, very easily. So further investigating the castration stumps, if there's an infection there, we can do with laparoscopy. And then sometimes horses after a big colic surgery, so one where they were thrashing around, we took them to surgery and made a big incision on the lower portion of their abdomen. Sometimes those horses can have scar tissue form in their abdomen that contributes to kind of ongoing, maybe feeling not quite right, having mild colic signs. So this technique, laparoscopy, helps us to go through the abdomen and try to determine if we see any scar tissue, and then cut it as well. Right, and so castration is likely a procedure that you're very familiar with as a horse person or somebody interested in horses. And most of the time, this is a pretty straightforward procedure. Sometimes, though, there can be complications that involve bleeding. So the spermatic cord that has to be cut in order to remove the testicles has big, big blood vessels. And occasionally the ligatures, so the knots that help to prevent the bleeding, can slip. And when that happens, horses can have extreme, extreme bleeding. One of the ways that we can deal with that bleeding, instead of rummaging around down at the scrotum trying to find those bleeders, is to put the scope into the abdomen, look right down at the inguinal ring. This is the inguinal ring right here, and we have spermatic cord going down into the inguinal ring like that. And in this case, you can see right here, the horse has been bleeding from this side. So we can use one of those instruments that helps us to stop bleeding and just go right across the spermatic cord, because it's the testicular artery in the spermatic cord that is causing usually that really profuse bleeding. So this can be a very helpful technique. Forgive the black and white images. I didn't have too many pictures of bladder stone removal, but this is laparoscopy is one way of removing bladder stones. I wouldn't say it's the most common by any stretch, but in certain scenarios, it can be appropriate more often when it's a stallion, or for instance, when you have a miniature horse. This can be quite effective. It is a fairly technically demanding procedure of kind of the group of procedures that we end up doing. And because we have to open up the bladder, which is what you're seeing right here, the bladder has a cut in it to be able to pull the stone out. There is some degree of debris from the bladder and contamination into the abdomen. But you can see on the right here, the instrument is grasping the stone, and then there's a little basket, a catch bag right down here that will allow the stone to be brought out of the abdomen. All right, so that's a pretty whirlwind adventure through the many different ways that we can use laparoscopy. Again, hitting on some of the limitations. We've talked about these kind of sprinkled through, but instrument length is one of those limitations, particularly when we're working in quite large horses. We're on the left side and we're trying to accomplish something on the right side. Sometimes that can be a problem for us, mostly because we get a lot of these instruments from the human world. And so they're designed to be able to cross a human abdomen very easily, but obviously the horse abdomen tends to be larger. So you can see in this case where we are taking out a bladder stone, our instruments are right to the hub in the cannula. We're just right at the very end of where our instruments can reach. The other big thing is that the horse has to be able to tolerate a standing procedure in some cases. So the horse has to sedate well. We need to be able to numb their flank adequately. And it generally has to be a horse that we feel pretty safe around. Despite the sedation and the numbing, kicking sometimes still happens. And we want to keep ourselves, our personnel in the operating room, and the horse themselves as safe as possible throughout the procedure. And then a full GI tract, so a horse that has just been eating and eating hay all the way up to the time of surgery, that is a bad deal for us. It takes up a ton of space in the abdomen. It's really hard for us to see what's going on. So the fasting, like I mentioned, is a big part of our preparation for surgery. And then, like we mentioned as well, when we're evaluating certain parts of the body, really we can focus on certain organs, certain portions of organs using laparoscopy, and the decision for standing or under anesthesia, left flank, right flank, that all kind of plays in depending on what exactly we want to accomplish. All right, so like I mentioned, and just to make sure I don't create any confusion, when we're talking about laparoscopy for colics, we're not talking about these horses that are very painful, very bloated, and have very bad intestinal problems. We're talking about horses that tend to be more chronic colickers, those that have weight loss issues or chronic diarrhea issues, or in cases where they've, say, had an entrapment of their colon in that nephrosplenic space or the epiploic foramen, and we're trying to prevent any sort of recurrence of that problem. All right, so in conclusion, laparoscopy can improve our visibility and access to some or even many organs. There's excellent feasibility in preventing recurrent colic of certain types. We can decrease the pain and oftentimes the costs associated with recurrent colic. And laparoscopy can be an option for investigating chronic colic or weight loss. And generally with laparoscopy, we facilitate a fairly rapid return to activity or athletics. So thank you so much for joining me this evening. I'm happy to try to answer your questions, and just acknowledgements to the many people that I work with, and along with residents, technicians, the students that help get everything done in the hospital.
Amazing. Thanks so much, Dr. McOnie. We do have a few questions, if you wouldn't mind taking a stab at these. So the first one is, how would you know when the nephrosplenic preventative surgery is warranted?
That's a great question. I think the answer probably differs slightly depending on the frequency. So first of all, I would say frequency. If the horse has had a nephrosplenic entrapment at least once before and is on their second, I would say absolutely you should be doing this. Frankly, a lot of us would do it at the first occurrence, because some of these horses do tend to recur and recur. So probably depends a little bit on your horse's overall frequency of colic, how well you think they would tolerate surgery standing like this. certainly if the horse has developed a nephrosplenic entrapment and has not resolved medically. So if you're considering surgery for the nephrosplenic entrapment, doing it standing with the laparoscope should be an option or should be a consideration, because fixing the horse and ablating the space, so preventing, can occur at the same time. So sorry, that's kind of a weaselly answer, but I would say really a lot of us would fix or ablate the space at the time of the first entrapment, and I would say maybe a larger group would do it after or at the second entrapment.
Excellent. Another question about the same procedure, a question about whether or not the horses mount an immune reaction to the mesh that is used for the ablation.
Oh, yeah, that's an interesting question. So there doesn't seem, so the meshes that are used are a pretty benign material. And no, we generally don't see a really adverse dramatic immune response to the mesh. Usually what we end up seeing, which is a normal response, is ingrowth of tissue, scar tissue into the mesh, and that kind of helps the mesh integrate and stabilize in the tissues. I suppose it is possible that if a horse had a bizarre allergy, in theory, they could mount a crazy immune response, but that definitely would not be a common occurrence.
Excellent. Another question just about the frequency of the inguinal ring not closing completely following castration. Is that a common complication?
Oh, okay. So the inguinal ring size and potential for herniation. So that horses can develop essentially an inguinal or a scrotal hernia at different time points in their life. So usually it is a congenital or hereditary predisposition to either congenital or acquired hernias down the road. Ultimately, gosh, I can't think of the exact incidence in the massive population. It's probably in like the less than 5% of horses that develop some sort of inguinal or scrotal herniation, but it would tend to be within certain familial lines where we see an increased predisposition to scrotal herniation or inguinal herniation, because that group of horses has larger inguinal rings. There are also certain breeds, particularly standardbreds and draft horses, that tend to have larger inguinal rings. Those are the ones that we usually kind of prescribe certain types of castrations for instead of maybe a field castration.
Excellent. And we'll wrap up with one final question. Are there any indications for laparoscopy in bovines and other species as well, like sheep and goats?
Oh, yes. So at our hospital, probably the most common farm animal laparoscopy that we do is in pigs, and that would be a laparoscopic ovariectomy, so a laparoscopic spay in pigs. And that can be very beneficial from the standpoint of trying to prevent aggressive behavior in some pigs and trying to prevent uterine cancer, which they are particularly prone to. So that's a very common reason for laparoscopy in pigs. In cattle, so a lot of the time, if you're familiar with cattle, one of their major abdominal problems is a left displaced abomasum. Some people will correct those using a laparoscope or a laparoscopic assisted approach. That often ends up being a scenario where cost plays into the treatment for the animal if it's a production type animal. So that's not the most common way for us to treat cattle, but we do often remove ovaries in cattle, sometimes using the scope. And then we have also use the laparoscope standing in cattle to investigate after an episode of colic. So just like in horses, cattle can get really severe colic, they can have intestinal entrapments. So after we deal with their initial really severe stage, sometimes we need to go back and try to, say, cut a band that maybe we couldn't access very well that was entangling the intestine. So sometimes it would be a stage treatment for colic. And then in our small ruminants, would say probably the most common laparoscopy again would be removing ovaries or the uterus, and then repairing inguinal hernias as well in some of the small ruminants.
Excellent. We do have just one more question, which we're just a few minutes over 7. So I think if you don't mind, we'll go ahead and answer this one as well. Question about, can emergency entrapment colic surgery ever be performed laparoscopically, or would you always perform this open in an emergency type situation?
Yes. So that it would depend on a few other factors. So usually if a horse has a nephrosplenic entrapment, and they are extremely painful, and we are not able to make them very comfortable at all, and surgery is recommended as a result of that. Usually what accompanies that picture is that their bowel is very gas distended or very full. Usually they're painful enough that they won't stay standing. So usually those things mean that doing open surgery under general anesthesia is the appropriate choice for the horse. And sometimes that's because the nephrosplenic entrapment isn't actually the horse's only problem. So that in that scenario, the horse would be anesthetized to have surgery. Generally, we would not do laparoscopy on an emergency basis because we would still want to have essentially help to empty the horse's gut prior to the procedure. So even if the horse comes in on emergency, so sometimes they come in after hours to us, and we are able to treat them with fluids, we're able to hold them off feed, provide some other pain control for them, we would often treat them the next day or even the subsequent day after their intestine is emptied a little bit more. So in those cases, the horse is presenting on emergency, but they can be stabilized. They can be made a little bit more comfortable so that we can get them to the point where we can operate them standing.
Excellent. Thanks so much for taking the time to answer those questions. Just as a reminder to everyone, this evening's seminar was recorded, and you'll be emailed the link to the recording in the near future. A reminder to also register for the upcoming seminars. Our next seminar will be on October 15th. Dr. Lisa Fortier will be presenting on evidence-based veterinary medicine. Thank you again to Dr. McOnie for the wonderful seminar, and we'll see everyone next month.
No problem. Have a nice evening. Thanks for joining us.
Thanks, Kelly.